All right, everyone. Welcome to Pulmonary Grand Rounds. Today's speaker is our former pulmonary hypertension fellow. She's currently the chief fellow for the General Pulmonary and Critical Care Fellowship. Elizabeth today will be talking about exercise pathophysiology in pulmonary vascular disease, specifically in the realm of exercise pulmonary hypertension. All right.
Thank you, Dr. Singh. Hi, everyone. I'm Elizabeth, and today I'll be delivering a talk entitled Exercise Pathophysiology in Pulmonary Vascular Disease, Exercise Pulmonary Hypertension, and Beyond. I have no disclosures, and this is the CME number. So to get started, exertional limitations are the hallmark of pulmonary vascular disease, yet our field overwhelmingly relies on resting hemodynamics to define and classify these conditions. However, exercise provides a more physiologic and provocative lens. It's under stress that the pulmonary circulation and the right ventricle reveal their reserve. In health, these systems are able to accommodate the rising flow of exercise. In disease, however, exercise exposes the earliest signals of dysfunction, long before our resting measurements declare themselves. This is why I think exercise pathophysiology is so fascinating and what I hope to impart on you today. In this vein, invasive cardiopulmonary exercise testing is a fantastic tool in the right patient population that allows us to better integrate a patient's symptoms, their gas exchange parameters, and their hemodynamics into a mechanistic framework that not only reflects the patient's lived experience better, but also advances early diagnosis and ultimately treatment of pulmonary vascular disease. So with this in mind, our learning objectives for this talk will be to characterize normal exercise hemodynamics, to analyze the abnormal pulmonary vascular response to exercise and pulmonary arterial hypertension. We'll trace the evolution of the definition of exercise pulmonary hypertension and discuss its prognostic and therapeutic implications. And finally, we'll evaluate the role of advanced or invasive cardiopulmonary exercise testing in a PH patient population specifically. So we'll start with a case. We have a 65-year-old female with a medical history significant for systemic sclerosis associated with pulmonary arterial hypertension. She comes into clinic and says that she's had significant improvement in her cardiopulmonary symptoms since starting treatment for her pulmonary hypertension, but she still has life-limiting persistent exercise limitations. She undergoes a non-invasive surveillance evaluation, and all of her routine testing looks reassuring. Her CT chest is stable, her PFTs are unchanged from prior, her echo actually looks better than before she started treatment for her pulmonary hypertension. Her RV remains slightly dilated, but it has preserved function. And her cardiac biomarkers have improved. Her NT-proBNP is now 320 from a prior value above 1,000 prior to starting treatment. And otherwise, her serum studies are unremarkable. Initially, the patient had severe precapillary pulmonary hypertension. She had a PA pressure of 48, a wedge of 4, a depressed cardiac index, and a PVR of 13 Woods units. However, following treatment for her pulmonary hypertension, her right-sided pressures have improved, her PVR has decreased, and her cardiac output has increased. Thus, at rest, her hemodynamics are well compensated. So by conventional metrics, we might call this good disease control and at least feel good about ourselves that we're on the path towards it. However, the patient continues to have symptoms. Thus, we have to ask ourselves whether there are residual abnormalities that our routine assessments are failing to capture that could help us better characterize her disease physiology and therefore allow us to more carefully and successfully treat her. So I want to take a step back and talk about normal cardiopulmonary adaptations during exercise. So exercise is this beautiful process that requires the coordinated integration of the cardiopulmonary system. Delivery along the oxygen pathway from alveolar ventilation to mitochondrial utilization of oxygen must adapt in step with workload. The fundamental metric we look at is oxygen uptake, or the VO2, defined by the Fick equation. In healthy adults, this can rise nearly 20-fold during maximal exercise. This is achieved first through an increase in cardiac output driven by greater venous return, increased heart rate, enhanced cardiac contractility, and redistribution of blood towards exercising muscle. At the tissue level, the microcirculation and vasodilator mediators, such as nitric oxide, facilitate oxygen delivery, while oxygen extraction further augments systemic oxygen utilization. These processes are tightly coupled to ventilatory adaptations, and ultimately this balance of oxygen delivery, extraction, and our ventilation defines our exercise capacity. During exercise, the pulmonary circulation is asked to handle a several-fold increase in blood flow. It does this remarkably well through two key mechanisms: the recruitment of previously underperfused capillaries and the distension of already perfused vessels. But this is only really part of the story. We know that the pulmonary vascular response to exercise is not simply a matter of opening extra channels. It also reflects dynamic interactions with the left atrium, right ventricle to pulmonary artery relationships, ventricular interdependence, and age-related vascular stiffness. Understanding these nuances is what allows us to distinguish normal from pathological responses to exercise. The pulmonary vascular resistance, or PVR, and the total pulmonary resistance, or TPR, capture related but distinct physiology during exercise. PVR isolates the precapillary pulmonary arterial component, while TPR integrates both PVR and the contribution of left atrial pressure. On the bottom portion of the graph, we see that PVR during exercise is remarkably stable because of the unique design of the pulmonary circulation, which is adapted as a high compliance and low resistance system. By contrast, TPR, which incorporates our wedge pressure, has a distinct response. In younger adults, which we see in the green and orange curves, the wedge rises minimally with exercise, so your total pulmonary resistance falls. In older adults who often have impaired diastolic reserve, the wedge rises earlier during exercise, blunting or reversing the decline. The key point is this: the stable PVR reflects preserved pulmonary vascular adaptability during exercise, while the TPR response reveals the contribution of the left heart and some age-related diastolic pathologies. And together they frame how we start to interpret exercise hemodynamics. What about the pulmonary artery pressure during exercise? This figure shows the pulmonary pressure flow relationship in healthy individuals during exercise. As expected, the pulmonary artery pressure rises in proportion to our workload and cardiac output, and the relationship is largely linear. Importantly, while most healthy subjects can maintain a peak pulmonary artery pressure during exercise below 30 millimeters of mercury, a significant minority, roughly 20%, exceed this threshold. This has also been observed in highly trained athletes where the upper limit of normal pulmonary artery pressure can approach up to 40 millimeters of mercury during exercise, reflecting their marked rise in stroke volume and cardiac output. We also know that the pressure-flow relationship during exercise, even in health, is age-dependent. In younger adults, which we see at the bottom of the screen, the slope is the slope averages just over 1 millimeter per mercury per liter per minute. In contrast, in older adults, who we see here, the slope is significantly steeper. This illustrates that even in health, pulmonary pressures rise more with flow as we age, reflecting vascular and ventricular changes that become apparent during exercise. And it underscores why in some cases, age-specific thresholds are critical when interpreting exercise hemodynamics. And then finally, in health, the right ventricle and the pulmonary artery are tightly coupled. So RV to PA coupling describes how right ventricular contractility matches pulmonary arterial afterload. It's quantified as the ratio of end systolic elastance, or EES, to arterial elastance, EA, and reflects the efficiency of RV adaptation to maintain stroke volume. During exercise, pulmonary blood flow increases and afterload rises due to changes in resistance, compliance, and wave reflections. In healthy individuals, the right ventricle is able to respond with a proportionally greater rise in its contractility. So EES, the load-independent measure of contractility, increases more than afterload, and the ratio of contractility to afterload is preserved or may even improve during exercise, reflecting a robust RV contractile reserve in health. So in summary thus far, in healthy individuals, the pulmonary circulation is able to accommodate the rising flows of exercise efficiently. Pressure rises are modest and proportional to cardiac output. The RV is able to maintain effective coupling to the pulmonary circulation. And aging seems to increase our load via mechanisms such as reduced compliance and higher left-sided filling pressures. So what happens in PH to contribute to exercise impairment? It's likely not due to a single defect, but reflects multiple interacting mechanisms. Maybe the right ventricle is central, struggling to adapt to rising afterload, but we also see contributions from abnormal left-sided filling, impaired skeletal muscle perfusion, ventilatory inefficiencies, and comorbid systemic diseases. And these overlapping abnormalities together explain the profound exercise limitations in pulmonary hypertension. And in the next section, we'll start to dissect these mechanisms. First, in PH, our peak VO2, or our aerobic capacity, is reduced, largely because cardiac output cannot rise adequately under the burden of RV afterload. And by the Fick principle, this depressed forward flow constrains our oxygen uptake. Second, we know that abnormal gas exchange in this population adds to the limitation. There's increased dead space and impaired diffusion, which leads to hypoxemia and hypocapnia, an excessive ventilatory drive, an elevated VE to VOCO2 slope, and an abnormally low end-tidal carbon dioxide, which are all markers of ventilatory inefficiency and hemodynamic severity in this population. These effects are often compounded by hyperventilation due to increased physiologic dead space and increased chemosensitivity, perhaps related to impaired RV relaxation and some increased sympathetic activation. We know in the population of patients with PAH, there is impaired pulmonary vascular distensibility as well. This figure from Dr. Singh and colleagues illustrates pulmonary vascular distensibility across different populations. At peak exercise, patients with PAH, here on the right of the screen, show the most severe impairment in distensibility compared with other disease groups. And importantly, in this study, distensibility seemed to be an independent predictor of right ventricle to pulmonary artery coupling during exercise, suggesting that the failure of the small pulmonary vessels to distend appropriately contributed directly to impaired RV adaptation and exercise limitations in this population. Patients with PH also have abnormally high pulmonary artery pressures during exercise. This figure illustrates the pressure-flow relationship during exercise. In healthy individuals seen here, the slope of the mean pulmonary artery pressure to cardiac output is shallow, approximately 1 millimeter of mercury per liter per minute, consistent with a preserved pulmonary vascular reserve. In contrast, patients with PAH, seen here circled in purple, exhibit a markedly steeper slope. This reflects impaired pulmonary vascular distensibility, increased right ventricular afterload, such that even modest increments in flow result in a disproportionate increase in pressure. The abnormal slope of the mean pulmonary artery pressure to cardiac output relationship is therefore a physiologic hallmark of pulmonary hypertension, capturing the loss of reserve in the pulmonary circulation and helping to explain the early onset of exertional limitation. Patients with PH also have abnormal right ventricle contractility and abnormal RV to PA coupling. So I want to spend a little bit of time on this slide. This shows some results from invasive cardiopulmonary exercise in testing and the impact of exercise on RV contractility and coupling in patients with pulmonary hypertension. Panel A here shows end systolic elastance, which remember is our load-independent measure of RV contractility. In patients with PH, which we see over here, our contractility is already elevated at rest. So our RV operates at a higher baseline to overcome increased afterload. But it fails really to increase further with exercise. So contractility is perhaps maximally increased at rest. In panel B, which shows our arterial elastance or a measure of afterload, we see that afterload rises in both groups, but the increase is greater in patients with PH, reflecting the heightened pulmonary vascular load of this disease process. And panel C shows the net effect on RV to PA coupling, expressed as the ratio of EES to EA. In controls, coupling is preserved because contractility can increase in proportion to afterload. In PH, the lack of further contractile augmentation means that the ratio falls, representing uncoupling. This uncoupling helps to explain the exercise limitation in pulmonary hypertension. The RV, again, is maximally stimulated and can't mount the additional response needed to meet the rising afterload that exercise demands. Another often overlooked contributor to exercise limitation in pulmonary hypertension is impaired systemic oxygen extraction, which has been described in patients with heart failure, as well as those patients with primary mitochondrial myopathies and post-viral syndromes and in chronic fatigue syndrome. To understand impaired systemic oxygen extraction in pulmonary hypertension, it's useful to go back to the Fick equation. Cardiac output is equal to our oxygen consumption divided by the arteriovenous oxygen content difference. In health, this difference should widen during exercise as tissues extract more oxygen. But in pulmonary hypertension, many patients reach peak exercise with a surprisingly narrow gradient, meaning that our venous oxygen content remains high. This suggests that there are some impaired dynamics between microvascular oxygen delivery, extraction, and utilization in this population. This is from a study that compared systemic oxygen extraction across patients with PAH, those with diastolic dysfunction, and those with systolic dysfunction. And what they found was striking. Patients with PH, which was mild in this population, had the lowest oxygen extraction despite having relatively preserved cardiac output and oxygen delivery. And the impaired systemic oxygen extraction seemed to account for their depressed aerobic capacity. In other words, in this population, peak aerobic capacity was limited not by oxygen delivery, but by the ability of the periphery to utilize oxygen. This highlights that pulmonary hypertension is likely not solely a pulmonary vascular disease. It has systemic manifestations, with impaired oxygen utilization perhaps playing a key role in exercise intolerance. Why might this be the case? The mechanisms are multifactorial. Skeletal muscle in pulmonary hypertension shows reduced capillary density. There's some muscle fiber type shifts, and there is evidence of mitochondrial dysfunction. There's probably also systemic endothelial dysfunction and microvascular rarefaction that limits perfusion. And there are definitely inflammatory and metabolic changes that further impair oxygen utilization. I'd also like to briefly highlight here that pathologic hyperventilation may also play a role, which can contribute to a leftward shift of the oxygen hemoglobin dissociation curve in the setting of relative alkalemia during exercise. So in summary thus far, in patients with pulmonary hypertension, their aerobic capacity is reduced, their gas exchange and ventilation are inefficient, they have a loss of pulmonary vascular reserve, they have failure of right ventricular adaptation, and their peripheral oxygen uptake is impaired. So as we've discussed, in health, the pulmonary circulation can accommodate flow with only modest rises in pressure, while in established pulmonary hypertension, pressures rise more steeply. But between these two extremes lies a gray zone. Patients who may appear normal at rest, but who develop abnormal hemodynamics during exercise. And this is the concept of exercise pulmonary hypertension. Historically, exercise pulmonary hypertension was defined by a mean pulmonary artery pressure greater than 30 millimeters of mercury with exercise, a threshold first proposed in the 1970s and carried on into the early aughts. But this definition was abandoned when it became clear that healthy older adults and even trained athletes could exceed this cutoff at high workloads. In 2022, the European guidelines reintroduced the concept of exercise pH, but now defined by a mean pulmonary artery pressure to cardiac output slope greater than 3 millimeters of mercury per liter per minute, measured during invasive exercise testing. This slope-based approach better reflects pulmonary vascular reserve than any absolute pressure threshold. In this vein, exercise pH is defined as a mean pulmonary artery pressure to cardiac output slope greater than 3 in the setting of normal resting hemodynamics. So why do we care about this slope greater than 3? Because it's rarely observed in health. So this graph comes from a systematic review and meta-analysis, which found that while the pulmonary artery pressure to cardiac output slope increased with age, as we see here in the blue slope, which represents individuals greater than 60 years old, the upper limit of normal was never above 3 Woods units. So this supports using a slope above 3 as pathologic, even in older adults, and was part of the basis for its adoption in the current guidelines. We also know that this slope is prognostically relevant. In one of the largest studies available, analyzing over 700 subjects, the association between exercise pH defined by normal hemodynamics at rest and a slope greater than 3, the association was analyzed between that disease process and survival. And the presence of exercise pH was associated with a 2-fold increased risk of an event, even after adjustment for clinical confounders. Thus, exercise pH seems not to be a benign process. It identifies a very high-risk group. The PECSNet collaboration, which combines 23 expert pH centers, confirmed the prognostic value of this slope in one of the largest populations to date. They found that an abnormal slope greater than 3 was a robust, independent predictor of survival with a hazard ratio around 2. And this held true even in patients who had a mean pulmonary artery pressure at rest less than 20 millimeters of mercury. Again, validating exercise pH as both a prognostic variable and a possible early disease marker. There are some limitations of the slope. It may not be reliable at very high cardiac outputs. Slopes increase with age and they vary by posture. So reference values may not be interchangeable during supine and upright exercise. Respiratory swings at peak exercise can also artifactually influence values. And importantly, the slope itself doesn't tell us the mechanism of disease. On that note, it's important to recognize that the pressure to cardiac output slope may be abnormal in the setting of pulmonary vascular remodeling or left-sided cardiac dysfunction. And it's important to think about how to distinguish between left and right-sided contributions to disease. So this figure shows how the pulmonary capillary wedge pressure to cardiac output slope can help and may be more informative than a single resting wedge measurement. In healthy individuals, shown here in green, we see that a baseline wedge to cardiac output slope is around 1. But in patients with diagnosed HFpEF, here showed in red, the slope is much steeper, averaging around 3. And a threshold of 2 seems to cleanly separate the two populations. Alternatively, current guidelines also accept a peak pulmonary capillary wedge pressure greater or equal to 25 as evidence of HFpEF-related physiology. Post-capillary exercise pH or exercise HFpEF also seems to carry prognostic value. So here we see that patients with normal resting wedge pressures, but an elevated wedge to cardiac output slope during exercise have worse outcomes, including death and heart failure events. And interestingly, seem to be more likely to progress to elevated resting filling pressures over time. What's striking is that many of these patients do not look like the classic HFpEF phenotype at rest, raising the possibility that exercise testing may be diagnosing disease earlier before resting hemodynamics become abnormal. At the same time, it's important to recognize that in clinical practice, many cardiologists still favor an absolute peak wedge threshold as the diagnostic cutoff for HFpEF because it aligns more closely with established clinical disease phenotypes. But this tension just highlights the value of exercise responses for early detection and the fact that our definitions are still evolving with clinical practice. Additional hemodynamic measures to discern precapillary exercise pulmonary hypertension are more conceptual. These include an elevated transpulmonary gradient to cardiac output slope greater than 1.2, an elevated peak pulmonary vascular resistance or total pulmonary resistance, as these values may indicate remodeling with stiffening of the pulmonary vasculature. In practice, we might also look for our familiar non-invasive parameters that suggest pulmonary vascular disease, some of which we discussed before, including exercise-related hypoxemia, an abnormal widening of the AA gradient with exercise, a failure to decrease dead space fraction with exercise, an elevated VE to CO2 ratio, et cetera. And the question I and others have is, does exercise pH actually just signify early pulmonary hypertension? And this seems to be the case, at least for populations at risk of developing pulmonary hypertension. This is from a study of patients with systemic sclerosis with no or mildly increased resting pulmonary pressures. And in this population, it was found that PVR and TPR at peak exercise were associated significantly with age-adjusted mortality. On the left as well, we see the RRC curve for predicting 10-year mortality for the MPAP to cardiac output slope and the TPG to cardiac output slope, which showed that a pulmonary artery pressure to cardiac output slope greater than or of around 3.5 Wood units has excellent discriminatory ability. And these are extremely important insights as early detection of precapillary pulmonary hypertension in populations at risk, including those with systemic sclerosis and others like those with BMPR2 mutations, for instance, or a family history of pulmonary hypertension, or even chronic thromboembolic disease, may help to attenuate disease progression by allowing for the implementation of earlier treatment. The assessment of pulmonary arterial compliance and pulmonary vascular distensibility has also aided into explorations about whether exercise pH represents an early form of pulmonary vascular disease. It's been shown that patients with exercise pH or mild pH have reduced compliance, which suggests that compliance decreases prior to the overt appearance of pulmonary hypertension, and may support the notion that vessel stiffness contributes to the progression of disease by increasing things like pulse pressure and augmenting pulmonary artery dilation. Distensibility has also been shown to be reduced in patients with mild pulmonary vascular disease without overt resting pulmonary hypertension, indicating that dysregulation in this property is a relatively early finding in this disease process. This was investigated by Dr. Singh, who showed that decreased pulmonary vascular distensibility in exercise pH seen here was associated with decreased aerobic capacity and dynamic RV to PA uncoupling, again suggesting early resistive vessel pathology, similar to populations with HFpEF and elevated PR or combined pre and post capillary pulmonary hypertension and patients with pulmonary arterial hypertension. The question also often arises, should we treat exercise pH with pulmonary vasodilators? So I think exercise pH in the right patient population identifies early pulmonary vascular disease and can probably help to explain exertional dyspnea. Unlike resting pH, however, there are no guideline-directed or recommended therapies. Mechanistically, precapillary exercise pulmonary hypertension likely reflects endothelial dysfunction and dysregulated nitric oxide signaling, providing a rationale, at least, for using pulmonary vasodilators in this population. And there are limited data, mainly in systemic sclerosis patients and in patients with only mildly elevated resting pressures that suggest a possible benefit. For instance, in the study shown here, peak exercise hemodynamics were measured before and after various pulmonary vasodilator therapies in patients who had evidence of exercise pulmonary hypertension. And we see here on the right that post-therapy, there seemed to be improvement in peak exercise hemodynamic values, including PVR, mean pulmonary artery pressure, compliance, cardiac output. And then interestingly, this was the only study to date to show that the treatment of exercise pH seems to improve pulmonary vascular distensibility, which again is posited to be a sensitive marker for early disease detection in this population. So in practice, who do we treat? Those who have exercise pH, so they have an abnormally steep slope. Patients who have a pulmonary vascular phenotype defined by the invasive and non-invasive parameters that we've discussed. Patients who have little or no evidence of left heart disease, either hemodynamically and based on their risk factors for left heart disease, like age and atrial fibrillation, for example. And patients especially who have risk factors for the progression to overt pulmonary hypertension. And then finally, to justify the use of investigational treatments, we treat patients who have symptoms that are life-limiting. So in summary, thus far, we've learned that exercise pH is defined by a mean pulmonary artery pressure to cardiac slope greater than 3 with normal resting hemodynamics, that it's a mechanistically heterogeneous disease and it can be due to precapillary causes or postcapillary processes or a combination of the two, that it seems to be prognostically significant because it may represent early pulmonary vascular disease or early HFpEF, and that therapeutic implications remain investigational. So I'd like to pivot now to talk a little bit about invasive cardiopulmonary exercise testing. This is the gold standard diagnostic tool that unites these hemodynamics and gas exchange parameters during exertion. And it's the backbone of most of the data that I've presented to you today. Briefly, invasive CPET seems to be a safe and well-tolerated procedure with risks that are comparable to a resting right heart catheterization, provided patients are not unstable. And contraindications mirror those for standard cardiac stress testing with additional considerations related to catheter placement. The procedure is formed with a PA catheter inserted into the right internal jugular vein, and it's secured for stability. A radial arterial line is also placed for blood gas and oxygen saturation, which are essential for accurate fit cardiac output calculations. And the patient is connected to a metabolic cart. Here we use an upright cycle ergometer with a RAM protocol to allow for continuous hemodynamic and gas exchange monitoring. Exercise for the purpose of this test should really be dynamic because resistive or static exercises like weightlifting or hand grip exercises are not really associated with the increases in cardiac output that produce a meaningful range of pressure flow relationships. Each minute during the test, multiple data points are collected, including a direct fit cardiac output, intracardiac hemodynamics, and ventilatory parameters. And with these data, resistive properties and our slopes can be calculated, as well as a distensibility coefficient. And while there are certainly barriers to completing this resource-intensive test, the overall holistic value of invasive CPET for patients seems to be significant. And its performance at expert centers has been shown to reduce time to diagnosis for complex cardiopulmonary disease and unexplained dyspnea compared to traditional treatment and testing. And on our topic today, it's the only test that we have that can diagnose peripheral limitation to exercise or exercise pulmonary hypertension. I want to touch on a few procedural points with invasive CPET that I think are worth highlighting. One, like with resting catheterization, it's critically important to set a correct zero reference level at the level of the left atrium. In healthy subjects, there are usually negligible respiratory swings, but during exercise, these can become significant, especially in patients who have obstructive airways disease. So in all cases, our practice per the guidelines are to average values over 3 to 4 respiratory cycles. Obtaining an accurate wedge is difficult even at rest, so it's important to avoid pitfalls like over-wedging or incompletely wedging the balloon. And cardiac output is really best measured through a direct FIC if you have access to a metabolic cart. Finally, it's important to recognize that body position affects hemodynamics, and keeping these in mind is critical to adequately performing and interpreting test results. So who should undergo invasive CPET? One, patients with unexplained dyspnea who have had an otherwise unremarkable non-invasive workup. Patients who have suspected exercise pH, including those and especially those with risk factors for progression to resting pH. Patients who have suspected HFpEF, who have otherwise had an unremarkable non-invasive workup. And finally, patients with known pulmonary hypertension, but who have persistent symptoms despite optimized therapy. So in short, invasive CPET is best reserved for patients with persistent, unexplained exercise intolerance where your physiology can't be clarified or hasn't been clarified yet by your non-invasive testing. This slide shows how invasive CPET can help us to diagnose the mechanism of exercise limitation. We start by determining whether there's a pulmonary mechanical limit or if the limitation seems cardiovascular. If it's cardiovascular, we can separate impaired oxygen delivery from impaired peripheral extraction. And with central cardiac limitations, invasive CPET allows us to distinguish left heart disease, precapillary exercise pulmonary hypertension, or preload failure, which we didn't discuss today, where there are low filling pressures. In this way, the test gives us a structured physiologic framework to explain a patient's shortness of breath. So I'd like to go back to our patient, remembering that she's a patient who has a history of systemic sclerosis and pulmonary arterial hypertension, who normalized her resting hemodynamics after treatment, but still had persistent exercise intolerance. So because she had an unrevealing non-invasive workup, she underwent invasive CPET. I've highlighted a couple of findings from her invasive CPET. First, she had no pulmonary mechanical limit to her exercise, and she did have a depressed aerobic capacity of 65% predicted. Important because on her non-invasive CPET, her VO2 was approximated to be about 99% predicted. She was found to have an elevated mean pulmonary artery pressure to cardiac output slope, consistent with her known precapillary disease. This was supported by her hypoxemia, a dynamic widening of her AA gradient, and a lack of reduction in her dead space fraction during exercise, along with an elevated VE to VCO2 ratio. These all pointed to abnormal pulmonary vascular reserve, which was perhaps unsurprising, but remember, her resting numbers had completely normalized. Second, she also demonstrated an elevated wedge pressure to cardiac output slope and had a peak wedge pressure of 28 millimeters of mercury, suggesting that she had post-capillary disease, likely comorbid HFpEF, which is common in systemic sclerosis and an important driver of morbidity in this population. And then finally, she had an elevated peak mixed venous oxygen saturation and a depressed arteriovenous oxygen content difference in the absence of significant hyperventilation. This suggested impaired systemic oxygen extraction, highlighting that abnormal peripheral oxygen utilization was contributing as well to her symptoms due to mechanisms like microvascular dysfunction, endothelial dysfunction, or perhaps mitochondrial dysfunction. So in one test, we were able to identify 3 contributors to her limitations: precapillary pulmonary vascular disease, post-capillary physiology, and impaired systemic oxygen extraction. And this is the unique power of invasive CPET. It disentangles complex mechanisms that resting hemodynamics or non-invasive CPET alone cannot. Now, to be clear, this case is perhaps more physiologically representative than it is management altering. We didn't really overhaul her treatment based on this result, but the test gave us clarity we couldn't have achieved otherwise. It confirmed her limitation was multifactorial and explained why she remained symptomatic despite optimized therapy. And that insight is crucial for counseling and for tailoring supportive strategies. For this patient, it meant focusing more on managing comorbidities like blood pressure and volume status, and obtaining a cardiac MRI to rule out systemic sclerosis-related cardiomyopathy. For her impaired oxygen extraction, while there was no disease-specific therapy, this finding reinforced the importance of supervised exercise rehab, a proven adjunct in this population. In short, invasive CPET helped explain her physiology and gave us a framework to help refine her care. So in summary, today we've learned that exercise can unmask physiology in cardiopulmonary disease, that exercise derangements may suggest early prognostic signals of pulmonary vascular disease and left heart disease, that invasive CPET integrates hemodynamics and gas exchange to elucidate symptom etiology, and that understanding these disease mechanisms can improve patient care. And with that, I want to thank Dr. Singh and Dr. Joseph and the whole pulmonary vascular disease team who's taught me everything I know. Thank you.
Great talk, Elizabeth. Any questions here? I know Chauvin has a question always. Yeah.
Uh-oh.
Great talk, Elizabeth. Thank you very much. Just a reminder of how complicated and customized the body is when you sort of start to look at all of this. Just a great way of approaching thinking about it. I have two separate questions. The first one you actually just answered on your second to last slide about this patient was whether the therapy for precapillary pulmonary hypertension addresses the oxygen extraction impairment. This patient still had it, but the question is whether it got better. So that was the first question. The second question was, Indian filler tired of me asking, but I continue to believe that that aortic stenosis is repaired too late because they don't include markers of the pulmonary vasculature in that. And so I was wondering if there's a role non-invasively in looking at pulmonary vascular resistance and exercise, as adding that to sort of one of the criteria, what your thoughts are about that. Thanks.
Thank you. Regarding your second question, I think there's significant use of exercise testing to guide cardiac interventions, particularly in the setting of valvular disease, because often our resting measurements aren't capturing the severity of the pathology at peak exercise. And so, at least in our lab, we do not infrequently echoes during exercise, focus on the valve at question to demonstrate that either the valvular pathology itself worsens with exercise or that the hemodynamics worsen with exercise due specifically to the valvular pathology. And that can be used to kind of guide the interventionalists at intervening earlier. A lot of, it's a common patient that gets sent to us for unexplained dyspnea, and they happen to have moderate valve disease. And, we think that the valve disease is probably contributing more than some of our colleagues might think. Whether pulmonary vasodilator treatment or some of our newer therapies actually improve systemic oxygen extraction in patients, I think that's a fascinating question. The exercise test, Dr. Waxman's exercise test with sotatercept, I think tried to look at this, but I don't think that it was conclusive that the medication was improving oxygen extraction, but I think that's an area that I'm definitely interested in, and others as well.
All right. It was a great talk, as always, Elizabeth, as always.
Thank you.
Very nice. So now I had a couple of questions for you. So this MPAP over cardiac output, which we are
So, sorry, can you repeat that?
MPAP over cardiac output,
Yeah.
the slope. From the basic mechanisms you mentioned, the 5 mechanisms, this is the loss of reserve probably related to that. But like, what do you think? You think it's related to that mechanism mostly? That the slope between the MPAP and cardiac output?
Yeah, I think it just highlights like a resistive vessel vasculopathy that increases the afterload out of proportion to the increase in contractility that the RV is able to mount, thus that these small increases in output just are leading to disproportionately increased pressure. I think it's probably resistive vasculopathy.
So it can be both. It can be loss of vessels,
Yeah,
loss of
yeah.
reserve, and then loss of reserve can be the distensibility is coming down of all the vessels. so
Yeah,
causes
that
them.
would be my
Just,
my
yeah,
guess.
just wanted to
Yeah, if
see
you
what your
have
thoughts
other-
are. That's
other
probably,
thoughts.
is
I mean, it
that,
could also, I mean, I think that we also saw that left-sided filling dysfunction can also increase the cardiac output, the PAP to cardiac output slope. So I think definitely diastolic dysfunction can, diastolic dysfunction, increased filling pressures
talking about
contributes to an
left
increase.
ventricular diastolic dysfunction adding to it?
Yeah, in the
okay.
right patient population.
So the next question is related to that, which is really interesting thing, because one of the mechanisms of the 5 things that you said, this impaired extraction is very interesting. It's a different vascular bed. It's a totally different vascular bed, different physiology, different level of NO. Everything is different in that one. And you mentioned mitochondrial dysfunction, microvasculature. How do you think this happens between these two vascular beds? Why this? Why? Like, what's the actual mechanism that you think is
I
causing
mean,
this?
I think a lot of this, I think there are probably a lot of similar mechanisms where the same similar mediators of endothelial dysfunction that we see in the pulmonary vessel bed are at work in the systemic circulatory bed. You know, we have the same hormonal metabolic mediators in the systemic circulation. So I think that's part of it. I think that would probably be my
Do you think a cytokine
best
release from the
guess.
right side that is not cleared going to the left side causing this issue at the microcirculatory level? Something like that.
Yeah, or that it's a systemic, that there's just a systemic, it's a systemic disease process.
Yeah, it's very interesting. So the last, I mean, I don't know the answer to this.
But I don't
just
know the
wanna-
answer, you know.
Yeah,
obviously.
like if anybody has any interesting thought, because this is coming up again and again in different disease, right?
For sure.
If there is anything. And then the last one is more of a,
And I will say
Right.
one last thing is
Uh-huh.
the study that I showed was interesting. The reason why I included this, and I didn't really go over it, but the study here, where this group was able to show the deranged systemic oxygen extraction, these patients had very mild pH, and so their oxygen delivery was preserved.
yes.
And they still had extraction issues, and that was their main that was the main contributor to their impaired VO2. So kind of just very, very interesting. And maybe they had more of that early disease physiology or that exercise pH phenotype where they had these systemic manifestations of disease, but they hadn't overtly manifested.
Let's see if
Elizabeth,
Richard has any-
I just had a thought. You presented the scleroderma case, and we know that scleroderma is a diffuse vasculopathy. And historically, the most common cause of death in scleroderma was renal,
Mhm.
right? So I wonder whether that plays a role in the fact that your patient had, in addition, a problem with systemic oxygen. Comment?
For sure. And this was the perfect patient because she had systemic sclerosis. And so I think she was ripe to have both the right-sided disease. She had risk factor for left-sided disease too, and the systemic vascular disease. And it's been shown, you know, we know that patients with systemic sclerosis, even in the absence of overt cardiovascular disease, have impairments in their peripheral oxygen extraction because it's the systemic microvascular disease. And so it's, you know, did she have this issue because of pH or her systemic sclerosis? I don't know, but it's common enough in pH patients without systemic sclerosis that I thought it was illustrative to at least.
Another thing
go
you
through.
touched on, it sounds like an evolving area, and that's early treatment. I know that our group is interested in this, and it's an international question going on right now. How close are we to be treating these patients that would not otherwise have gotten treatment? And I think you showed one slide that showed some efficacy. Comment on where we are?
I would say that if the patient ends up at an institution that has access to invasive cardiopulmonary exercise testing and it's picked up and they're symptomatic, they're probably going to be treated. I would say that, at least in my limited experience, patients don't tolerate treatment as well as patients with overt pulmonary hypertension. And they might not tolerate the systemic vasodilatory effects or for other reasons, which is why I think these conversations are always kind of risk-benefit discussions with the patient. But I think a lot of patients with exercise PH or early PH, even early PH in particular, are going undiagnosed and are not coming to see treatment until their disease has progressed and their symptoms have progressed enough that somebody's index of suspicion or, spidey sense is raised that they might have resting PH.
Yes. So it's like Clara has a question. I can wait after, Clara, you wanna answer? Here we go.
Okay,
Go ahead.
thank you, Elizabeth. Just a somewhat related question is, do we have a sense of how prevalent isolated exercise-induced pulmonary hypertension is? Is it on the same order of magnitude of pulmonary hypertension? I think you made a case, the epidemiological outcomes are worse in these patients. It sounds like there may be a trial going on as well, looking at whether, do we know whether treatment improves symptoms?
So I don't have a sense of how many patients have exercise PH. There's more data on patients who have early pulmonary hypertension. So these populations are often grouped together. I don't know if you have a sense, but it's very uncommon because it's
Very uncommon.
uncommonly diagnosed because people just don't have access to the testing
I see.
that will
makes
diagnose
sense.
them.
One last question. I think in your slide indicating some of the mechanisms of exercise impairment in pulmonary hypertension, you indicated that cerebrovascular bed was, and I was just curious as what's going on there.
I think this again, there have been some interesting studies on the cerebrovascular impacts of pulmonary hypertension, which again, I think just speaks to this notion of PH as a more systemic disease, perhaps causing some kind of more general symptoms of fatigue, but whether it specifically causes shortness of breath or breathlessness, I'm not sure.
So if I just had one practical question for you, because one of the indications you said is unexplained dyspnea. So together with that, as you know, I have a lot of COPD patients who are more short of breath than what they're supposed to, So this unexplained dyspnea, I'm sure you don't get in all the patients with unexplained dyspnea. Can you discern that a little bit for us and an update on where we are with vasodilator or PH therapy in COPD? Like, what's the update on that?
Sorry, so
So the unexplained dyspnea, which patient would you take
send
really?
for test?
Yeah.
I think that we all see patients with unexplained dyspnea all the time, and we don't always send them for invasive CPET. I think you have to have a high enough index of suspicion that they have a specific disease process, and those processes are pulmonary hypertension, including exercise pulmonary hypertension, HFpEF, or you think they have an issue with their peripheral oxygen extraction. And then within these three categories, there's more specific. So do they have symptoms of chronic fatigue syndrome? Do they seem to have symptoms that started after a viral illness? Do they have a history of Lyme disease, for example? Do they have connective tissue disease or COPD that you think might predispose them to having muscle-related pathology? And then, obviously, I think patients who have risk factors for HFpEF or pulmonary hypertension. So HFpEF's its own bucket, but for pulmonary hypertension, family history, genetic mutations that you're aware of, a history of what we know are the comorbid systemic diseases, like HIV or connective tissue disease. So I think all of those things would point you to wanting to get more information because you think that the testing will have therapeutic implications for the patient, or you think that the patient would benefit from a diagnosis, even in the absence of you being able to provide them with disease-directed therapy. And there is a population of patients who I think benefits significantly from that, especially our post-viral patients who have gone to multiple subspecialists and are high utilizers of healthcare resources, for whom a diagnosis is really important.
There's a question online from Fatima. The first one is there any data on how a prior PE affects the mean PA to CO or the wedge to cardiac output relationship in the absence of CTEPH? Repeat it.
So there are data showing that patients with chronic thromboembolic disease do both have exercise pulmonary hypertension and or have a peripheral limitation to oxygen extraction. And this is a really fascinating patient population because often for these patients, there are clear management implications, especially if they have surgically accessible or angiographically accessible clot. And so, again, these are small case reports and single system experiences. But for instance, if a patient with chronic thromboembolic disease with significant clot burden has exercise pH, you may be able to make a case for surgically intervening on that patient, especially if they have a high symptom burden. But I can't point you to the actual data off the top of my head.
Question 2 is, among patients with unexplained dyspnea, what clinical features increase your suspicion for the presence of exercise pH? How do I identify the population I need to advocate for an ICPET?
That's a really difficult question. I would say that any patient who has exertional limitations has an issue that needs to be addressed. And the question is how deeply you're going to go to address that issue. Often these patients don't have significant echocardiographic abnormalities or cardiobiomarker abnormalities to point you in that direction. So for me, I think it's the clinical history. And again, thinking about their risk factors for disease, for their risk factors for pH in particular. And so I would do like your full non-invasive pH workup with autoimmune serologies, cardiac biomarkers, a very strong family history prior to sending them for exercise, testing. There's some more clinical, there's like a stronger clinical phenotype, I think, for patients who have a peripheral limitation to exercise where they present with predominant symptoms of fatigue and post-exertional malaise in particular, and again, have a good history to support their risk for having that disease process.